This week on the Back Table Podcast.
I think most people are getting trained in UFEs, but I do believe it's a very attainable procedure for like any young IR docs who maybe don't have a whole lot of experience with it. I mean, selecting the uterine arteries is one of the easier things that we do.
Hello and welcome everyone to this week's podcast with Back Table, your resource to connect with your IR colleagues and share cases, techniques, and the ins and outs of the devices in your cabinets. As a reminder to our listeners, our app is free to download on the iTunes Store, or you can find us at backtable.com. This is Michael Barraza returning as your host. Today I'm thrilled to welcome Keith Pereira and Chris Beck to discuss their experiences and approach to uterine fibroid or uterine artery embolization. We'll start with some introductions. Myself, I just finished my IR fellowship at Penn, where we did a lot of UFEs, both transfemoral and transradial. Now 3 weeks into a private practice gig in Nashville, I'm yet to see a single UFE consult, which I'm hoping to change. Moving on to Chris, could you please tell us about your background and the role UFE plays in your clinical practice?
Sure. And first, thanks, Michael, for having me on the podcast. So my name's Chris Beck. I've been on the podcast a couple of times. I'm a private practice interventional radiologist in New Orleans. And originally, when I joined my practice, we were doing, maybe 5 or 6 uterine fibroid embolizations per year. And it was a part of the practice I was very interested in growing. And it's come a long way. I mean, I think we have a ways to go, and I was hoping to solicit some of the advice from Keith. But now we do about maybe one UFE, or maybe one UFE every 2 weeks, or maybe one UFE every week. So we've picked up the volume, but I certainly think there's room for growth.
Okay. So now moving on to Dr. Pereira. Keith,
hi, Mike.
You've managed to become a well-respected and outspoken advocate for this procedure in our community. Could you share with us how you got there and why this has come to represent such a large part of your practice?
Yes. Thanks, Michael. This is an awesome platform. I've been hearing a lot of other talks on this, and it has been really nice. Getting back to, so, I did my fellowship a couple of years ago, 7-8 years ago in New York, and I was in the Bronx where I started doing uterine fibroid embolizations. And, I was amazed because, back in medical school, we did not hear about UFE. No medical student hears about UFE. Doing your residency, you sort of hear about it. And then, when you start doing these cases, you're like, oh my gosh, what the hell is going on? UFE is in outpatient simple procedure, takes about 45 minutes to an hour. Patient goes home the same day. What is the comparison to hysterectomy? So it was pretty impressive. And, being in the Bronx in New York, that we had a fair amount of patients who came for UFE. And, subsequently, I moved to Miami and I didn't see any UFEs. And I was like, oh, this is weird. In New York, so many UFEs, and Miami, no UFEs. And, we spoke to a lot of people around, and, there was a resistance from other physicians to send us patients and stuff. And, so I sort of thought it was a regional thing where, some places there is a lot of UFEs, some places there's not. And then I moved to St. Louis University in St. Louis, Missouri, about a year and a half ago. And, I think I've really been pushing for a robust UFE practice here. And, we have a long way to go, but things have moved significantly from a long time. This practice didn't do any UFEs a couple of years ago. We're doing a significant amount now. It's growing every month. So it's been a long way. I think, we've come a long way, and there's a long way to go. Remember, there are 400,000 hysterectomies for fibroids every year in the U.S. Okay, so there's a lot of patients out there who need UFEs. A lot of patients. Yeah,
that's incredible. That's even larger than the numbers I found. I found 180,000 a year, or 30% of the hysterectomies in the United States are performed for fibroids. So, in your opinion, generally, what proportion of those do you think are better suited for UFE?
Well, every patient is suitable for UFE, right? A patient who's not a surgical candidate, a patient who's a surgical candidate, every patient is suitable for UFE. Now, which are the patients we sort of, we don't consider them to an ideal candidate are the ones who are younger and who may want to get pregnant. There's some evidence, but this is back in 2008. There's a nice paper out of Europe, which has reported a higher incidence of infertility, a higher incidence of early loss of pregnancies and stuff with UFE. That being said, at that time, the American College of Gynecology came out with a statement saying that it may not be the preferred treatment indication for people who want to get pregnant, young women who want to get pregnant. Things have come a long way. There have been a lot of papers coming out now. There's a recent paper come out of Dr. Pisco in Portugal, which shows, things are not the way we thought it was 10 years ago. There are various new techniques that can be used, partial embolization versus complete embolization. So there are a lot of techniques that can help to retain pregnancy. So I think it's something that will evolve over the next few years about the pregnancy part of it. The rest of it, there is almost no contraindication. Again, there is a myth that pedunculated fibroids are a contraindication. Yes, it is a relative contraindication, but not an absolute one. Again, submucosal fibroids, which are along the inner side, again, contraindication. I don't think it's a contraindication as long as you speak to GYN and the patient and she knows that this fibroid could slough out and they're aware of it. I think it's not a contraindication anymore. So essentially, there's no contraindication right now. Relative contraindication is a young woman who may want to get pregnant.
Okay, so it sounds like your practice regarding UFEs has really evolved in recent years, but as for all of this, there's plenty of room to grow. As of now, where do the majority of your patients come from? And if you could specifically touch on your relationship with OBGYN.
OBGYN has been, it's been difficult, it has been difficult. And I think as vascular interventional radiologists, we have to move beyond thinking of somebody is going to refer a patient to us. I think that we have crossed that phase of our specialty. We have to think of ourselves being almost like a primary specialty. We have to be the physicians. We have to be the primary care physicians to these patients. So yes, we have to have GYN. They're our colleagues. They're good to us. We have to have them on board. I absolutely agree. We have grand rounds for them. We talk to them about this. We do a lot of stuff to educate a lot of GYNs about this alternative option. But I think, as I said, we have to move on. We have to touch the patient. We have to speak to the patient directly, communicate directly, tell them about the advantages, about the disadvantages, why is it different from hysterectomy. And, patients should know that this is a treatment option, and it is a very time-proven and time-tested treatment option for uterine fibroids.
Okay. Chris, what about you? What's your relationship like with OBGYN?
So we have a pretty good relationship with the OBGYN doc. So there's LSU Hospital, which operates a lot at the community hospital that I work at. And then there's some community private practice OBGYN. And, originally it just took me getting out there and meeting some of the OBGYN docs and letting them know that we did UFEs for a long time. I think they were interested in having that option for some of their patients to see an interventional radiologist. And really? My group, for whatever reason, they just weren't all that interested in growing that part of the practice. So, for me, almost like getting into my practice, one of the small hurdles to jump over was just to introduce myself and let them know that I did the procedure. And then another thing that I did to build the practice, we deliver a lot of babies where I'm from, and we had a handful of cases. They kind of came in like a small rash of postpartum hemorrhage. And so, I did uterine artery embolization, setting up, postpartum hemorrhage, not exactly fibroid embolization. And when the OBGYN, they always come and they'll thank you afterwards, and you're, helping them out in a jam. And I'll say, you know what, this is a great case, happy to help you out, but now you owe me a couple fibroid patients. And then we would kind of have a quick laugh about it. And I'm like, but seriously, you do.
That's pretty cool.
But very much our relationship with OBGYN, it's been more collaborative than competitive. But I kind of agree with Keith. I think we've moved past the point where, we're sitting back and waiting for an OBGYN to counsel the patient and then tell them, hey, I think you're a better candidate for fibroid embolization. I see a lot more practices and even some guys in New Orleans that, direct referrals from either primary care physicians or some patients self-refer. I think if you do a good job of marketing yourself, nothing cheesy, but, just make yourself available either on the internet, and then SIR has kind of a mechanism for that I think patients will try and get in touch with you. But to answer the question, ultimately, we kind of have a collaborative approach with OBGYN, and they're sending me some good cases. I mean, I think there's some untapped resources and some reluctant refers, but, I still intend on working on them. And, I think that we offer a good procedure, and there are a lot of candidates I think there are a lot of patients who bring it up themselves to their OBGYN, and then that prompts a referral.
Well, Chris,
that's an interesting point he raised. I think besides getting the self-referrals, it's important to educate people to speak to the GYNs about this treatment option. Just bring it up, because the moment they bring this up, a lot of GYNs are like, and I've seen that, they say, oh, yeah, you want this treatment? Yeah, but I'll send a referral to my closest vascular IR guy. So I think that's important. Know your treatment options. And SIR has been telling everybody, trying to educate people, know your treatment options. That's the important point. That's a good point, Chris.
Yeah.
And Chris, you brought up another important point about the self-referrals. Are either of you involved with any kind of marketing outside of, speaking to your doctors, like any kind of advertising or anything like that?
Keith, do you want to take that one?
Sure. Yes. We have been doing a lot of advertising. I'm working in a university hospital. It's difficult to get the finances to advertise, because these ads are expensive and everything. But yes, recently one of our marketing guys said, we've got an opportunity of an ad in a local daily. We have never done it before. Do you want to try UFE? And yes, it worked. We got 3 referrals from just one small ad. And this is like 2-3 weeks ago. So it's not unusual. I think ads is very important. More than that, I think a lot of awareness, using social media. I think social media is excellent. I did a small Facebook live interview for social media. There were like 5,000 views and a lot of impressions on it. So I think that's one thing. And coming on your TV, your local channels, they're always interested in something that affects society. So something that is so prevalent, 80% of women have fibroids, 50 to 80% of women. That's a high number. This is something that you should talk to your marketing team and tell them to talk to the media and tell them that this is something that people need to know about. We should not promote the procedure only. We should promote awareness of the people about this disease condition. And that's how people become aware of the procedure for it. So, and I think it's a social cause, We are physicians. We're just not proceduralists. We're physicians. We should make people aware of this disease condition, and there are options available for it. So, yeah, I think social media, TV media, and newspapers, I think very effective, and that's the way to go. These, as you know, these women are young. This is you're not your target population is not 65-year-olds. Your target population is 35 to 50. These are the women who go to the internet, who read newspapers, who look at TV. So these are people who want to know options. Easy population to target, really easy.
He does a good point in bringing up like the patient population of your fibroid embolization patients. I mean, they're 35 to 50, 90%. Maybe even I'd say virtually all the patients that I see have Googled the procedure, know something about the procedure, yes. and for the most part are pretty well informed on their options. And so I think that makes them in kind of a good patient population to target, like Keith said, with either traditional media like television, radio, or newspaper, social media. And, a lot of times like your hospital will have like a mechanism to help you along with that. I know in my practice, we're a private practice group that works, contract out with the hospital. So, there's nothing really in our practice budget to account for marketing, but there is someone at the hospital who's more than happy to like help get your name out And another avenue to think about with marketing is like whatever reps you might use for the devices that you use. They'll help you put together a little something like a little brochure or something that you can hand out for your patients.
Absolutely, that's a very good point. Unfortunately, I cannot do it because of the university has its own rules. But that is a great way of promoting your practice through reps who sell these devices. Yes, absolutely, absolutely.
Chris, you answered the question I was going to ask, which was how you would recommend somebody go about trying to build referrals. But say we're going with the rep system, contacting a rep to help him or her. to have him or her help you get a few patients in the door. What kind of rep are you targeting? Is it the embolic rep? Is it the catheters? Is it from your radial sheath? Who are you going to?
Well, yeah, that's a great question. I think for fibroid embolization, I usually go to the embolic rep. And that's just one way to go. Like I wouldn't bank on your rep really going the extra mile for you. In the end, it's going to be on you to kind of push this agenda as far as building up your practice. But I just think that sometimes, maybe not in Keith's practice, or if you're at a university setting, they have some rules against it. But in my instance, the reps, it's kind of a free for all. You can have the reps and they'll help you put together a dinner or a talk or a lecture for either physicians.
I see.
One of my partners who's over in Lafayette, which is a practice, it's a couple of ways. We cover a lot of different places. But he was telling me back in his day, he went to the public library and one of the reps helped him put together a little talk, and they invited some people to the community, and he said he got 10 referrals from that, and of those referrals maybe 5 went on to embolization. It's just kind of thinking a little bit outside the box when you're just trying to get started and getting the first couple patients in the door.
Yep, absolutely.
Now, are you both seeing all of your patients beforehand in clinic?
Yeah. Oh yeah. Well, clinic is the most important thing. The most important thing for any vascular IR practice. I think if anybody is not having clinic right now, you're bound to fail. I think it's an absolute essential. See the patient in clinic, and if required for the procedure, set up for the procedure, see the patient and follow up 3 months. And then after 3 months, I usually go to sometimes we do an email type of thing. So our vascular IR coordinator is emailing them for the UFS QOL scores so as to know how they're doing. Some of these patients do so well, they never see you again. Never seeing you again may be a good thing because they really do well. So routine follow-up is difficult sometimes with them. But, I think, that's how we go. I think clinic is so essential.
I totally agree with Keith. Although I was thinking how awkward it would be if I say that I didn't see any of my patients in clinic. After Keith just told us how essential it is. But I totally agree. I think that I see all these patients in clinic, and actually I don't even have dedicated clinic time, but there is usually some slow parts of the day that I know I can get away with seeing patients, and so I'll schedule those patients on varying days and see them towards the afternoon. But I see everyone pre-op. And, at that time, I'll actually put in a full H&P note. I think it's a good idea whenever early on, and even when you're a little bit deep into your practice, I take that clinic note. And one of the first questions I ask my patients is, tell me every doctor that you have. And they, tell me they have a PCP, they have a OBGYN, and they, maybe they have a neurologist or whatever. One, it gives you some insight as to what's going on with them, but also I see every one of those doctors on my clinic note and let them know, what I'm doing, when the patient's scheduled.
Wow. That's one,
nice. And one, it keeps the OBGYNs in the loop, and I think they appreciate that. And two, you never know, you send it to a PCP and they read that and they might just think about fibroid embolization when otherwise they might not have.
Yeah, that's a very good point. I don't know whether you guys know, but if you use Epic, you can get any physician almost everywhere in the whole country on your Epic. Do you guys knew that?
I only use Epic. I only use Epic at one of the hospitals, and I had no idea you could do that.
Yeah, you can copy any physician. Just put his last name out, and you can route it to him. It's pretty much. I just discovered this 3 weeks ago, so I'm really excited about it.
That's incredible.
Yeah, it is.
Yeah, I certainly don't have that.
Really nice.
So I wanted to take this opportunity to switch gears a little bit and focus on some of the technical points of the procedure. And so I was just going to ask you to go through a straightforward case, starting with how you select your access site, radial versus femoral, and then just take us through a case, the catheters, the wires you use, the embolics you use, and what your endpoint is.
Okay. So, as I said, clinic, in clinic, we have now started checking patients' radial. We've got an ultrasound in clinic. We start checking the radial, see the diameters, do a barbo. So, you're sort of set up for a radial procedure. So that, ahead of time, the techs, when the patient comes for the procedure, know how to set the room up and everything, have the radial cocktail and everything ready. So that's done in clinic. And we put on a clinic note, this patient appears suitable for radial access. So that makes things easier.
And is that based on pre-procedure testing, like a barbo test, or is it
Correct,
height play a factor in that? Do you have a height limit?
Height factor, not really, because I think now we have decent catheter sizes, and I'll I can touch on that in a little while. But I don't think height is any more a factor. I think it's barbo, and the size again. We have come down from, we used to start at 2 millimeters in the beginning. Now it's come down to 1.6. Below 1.6 is tough, but then there's always an ulnar artery. So I don't think there's almost no chance of you not being able to do a procedure unless, she's had a procedure before.
And
or there's something.
Do you accept barbo A, B, and C for transradial interventions?
Correct. Okay. A, B, and C. Correct. Yeah. I've even, just to prevent confusion in the room, I sometimes, switch from, I couldn't get radial access, for example, just go to brachial and finish the procedure rather than just move on the other side. So, that's a different conversation. But so that's done in clinic. Of course, we'll review the MRI. And I think the two things was to, if they don't have an MR, then get an MR. The other thing was endometrial biopsy. That was sort of the gold, everybody had to get an endometrial biopsy. We still try to get it if the patient has never seen a GYN or, has had an endometrial biopsy in the past, and then we may skip it. But as far as possible, we try to get these two things, MRI and endometrial biopsy. May move on to just an ultrasound. I think I'm very comfortable with ultrasound. If I can do an ultrasound in my clinic, I may not need an MR. MR it gives a lot of information. As radiologists, we want imaging, but as clinicians, clinicians don't get an MR for everything. And there have been studies which have shown that, MR is the cost of UFE versus hysterectomy is almost similar, and the similarity is because the cost of MR is added to the UFE. So I don't know. I think down the line, as we get more comfortable with this, we will start skipping the MR part of it. But as of now, we try to do MRs and endometrial biopsy with most of our patients.
Okay.
Yep. So
back to me and my fibroid uterus. I've got a beautiful radial artery. Can you walk me through my procedure, just from the access all the way to embolization?
So patient comes on the day of the clinic, gets set up for the radial artery. We stand on the left side of the room with the hands extended outside. The people have been using Embla cream on the hands for vasodilatation. I've not used it. I don't know the effect. But basically get access now. Access wise, I think radial access everybody's spoken about. It's pretty easy, straightforward. You do few of it, and you know how easy it is. The radial cocktail is pretty important. Verapamil 2.5, nitro 300, and heparin 3000. The Terumo slender sheath 4/5 French is golden. Never ever failed me. It just slides in as long as you get good access with ultrasound. It just slides in. So it's amazing. It's really amazing. So once you get access, we use the initially I started using the 4 French 120 Terumo Glide Cath. Great catheter, got a big end lumen, but sometimes it gets a little. It gets a little flimsy. It's not a strong catheter, so I've tend to moved on to the Word catheter, which is Merit has got a nice 5 French Word catheter, which is amazing. You almost go wireless into both the right and left internal iliacs, and then into the uterines without even a wire. as standard teaching goes, if you want to get into the right into the iliac, if you do contralateral oblique and vice versa. And then once we get into the uterine artery with the bigger catheter, with a 5 French catheter, I've always used a prograde. I know in a lot of outpatient practices, you want to save on a little bit of money because of the catheter, but I think we need to get beyond that horizontal segment of the uterine artery just to prevent any embolization in the cervicovaginal branches, especially younger patients. They lose sensations, and sexual function can be affected in the long term. So get beyond the horizontal branch, and then at that point of time do an angiogram. So far, no angiograms. And then do an angiogram, and then embolize with particles. Again, 5 to 700 is the standard. You start with 5 to 700. Try not to go below, because you may have a ovarian artery coming out of there, and then you can go up to 7 to 900 just to go to sort of stasis, but not complete stasis. Just stop short of that. I've seen a lot of people with pain when you go to complete stasis, and it's really not needed to go to complete stasis. So sort of prior to complete stasis.
Now, what about your embolic agent? Are you using embospheres or something different?
Embospheres for now, yes. I've used the embospheres. Some hospitals, we cover a few hospitals where we may have to use PVA particles. Not as comfortable with PVA as embolic particles, which is embospheres, yes.
Now, one more question on this. Does your endpoint change if you're treating for adenomyosis or postpartum bleeding?
Yes. Postpartum bleeding, you would definitely be more aggressive. You would want complete stasis for sure. And then probably even put gel foam on the way out a little bit, sort of pack it up with gel foam. Possible. Adenomyosis, you'd go with smaller particles, yes. 1 to 300 sometimes, if you really need to get the adenomyosis out. But yeah.
Chris, what about you? Can you walk me through your approach, what you use, and how you do this?
Sure. So, bypassing all the pre-op stuff. So, day of the procedure, patients in the cath lab. I do everyone femoral access. I'm interested in doing some radial cases, and every time I say that I'm going to do it, it's just either I chicken out or I just
I know the feeling, my friend.
What's that?
I know the feeling.
Don't cut me out again. Don't cut me out of this. It's going to change your practice. Oh my gosh, dude, you cannot imagine.
I hear. I mean, it's not as though I didn't train on radial access. It's just always something like we don't have the radial sheath, or like I don't have a slave monitor. So if I want to go radial, I kind of got to look over my shoulder or bring the arm down by the side and then work left-handed. I got 100 excuses, but anyway. So I go femoral access. Just a standard 5 French sheath. And once I'm in, I go up and over with a C2 glide, select the hypogastric, and then, hypogastric, usually, depending on where I am, I may negotiate the 5 French Cobra a little bit closer. I never get into the uterine with the base catheter. I usually just park it right outside, or, depending on how close I feel like getting. And then I use a Renegade microcatheter with Fathom wire to get into the uterine. And this is a good point to talk about it. If people, I think most people are getting trained in UFEs, but I do believe it's a very attainable procedure for like any young IR docs who maybe don't have a whole lot of experience with it. I mean, selecting the uterine arteries is one of the easier things that we do. But anyway, so once I'm in with the micro, I usually get in the horizontal branch of the uterine, and then I do a run. One of the tips I was taught by one of the guys who taught me how to do this was I put it on 1 frame per second, and so I'm not blasting them with radiation, and then I carry my run out to the venous phase. And, because you see the artery phase, you can do the artery phase on just like a blush of contrast. But what I'm looking for is any potential underlying ABM. And then once I feel comfortable with the run, I'm kind of analyzing like how much of the fibroid or how much of the uterus am I seeing. I'll embolize with 5 to 7 embospheres. And I like Keith, you start with 5 to 7s and you make up to 7 to 9s. And I use substasis also. I think a lot of people, even me early on, you over embolize. I don't know why. You just feel like you got to. And, what I do is I usually, kind of a rule of thumb is, 5 heartbeats, the contrast won't clear out, but you can kind of see it moving a little bit. And then, one thing you don't have to worry about radial, but I have to worry about is getting into the ipsilateral side. And so I'll do a Waltman loop with the same C2 glide and then get into the hypogastric and then subselect all over with the same micro.
Mm-hmm. So you do the Waltman loop with the C2 glide, huh?
What's that?
You do the Waltman loop with the C2 glide?
Yeah, I do it with the C2 glide. It makes it a little bit harder with the C2 glide. And if I'm having any trouble, I can just I can use another catheter. But usually I can get it with the C2 glide just so I can stay in the same catheter.
Does it ever get
We actually did it a different way at Penn for the ones that we did do radial. We would take just a long Berenstein and preload it with the 2.0 Tevdak suture, get it up into the abdominal aorta, and basically it's like the suture reforming technique used for Simmons. You do that, but you just basically keep going to get this huge loop that just goes all the way up into the abdominal aorta, and then you just pull it down to each side. It's actually very easy, much easier, I think, to select the ipsilateral that way.
Nice.
So to move on a little bit, when or if do you guys go out and look for the ovarian arteries?
Oh, that's a good question. To finish up my procedure, I almost always do a run in the aorta to look for like any ovarian collaterals.
I don't know. I think I should be doing it. If it is a large uterus and you have some suspicion, like for example, I like Chris's idea of doing this 1 frame per second. I think I should do that. That saves radiation. That's a very nice thing. I'm going to take that up. But if you do a long run, and you don't see a blush, you see a perfusion defect somewhere, then you know that there's something going on with some other artery. But beyond that, no, I don't do that extra run. I guess just laziness, but maybe I should be doing it.
For both of you,
for what it's worth, I think most of the time, if you're paying attention to your runs, you can tell that there's something not perfusing, which would prompt you to do the aortic run. It's out of laziness that sometimes I'm not looking as closely as I should that I do the aortic run. And I would say out of all the aortic runs I do, it's about 1 in 20 that I'll pursue anything off that. But
that's a good number. 1 in 20 is a good number. It's 5% failure. It's 5% failure. Yeah, that's a good number.
Keith, I'm sure you remember the case I shared with you with that massive ovarian mental artery. Certainly don't see that every day. But to say we're done, we're embolizing. What do you both use as your preferred tool or technique for hemostasis?
Well, it sounds like Keith is radial, so you use TR band, right?
Yeah, TR band, yeah. 30 minutes TR band, 35 minutes out.
The Vasostat, we use that at for radial intervention, so it was awesome. It maintains a little bit of flow in the artery, so you're not totally occlusive. It's just enough to, for hemostasis. What about you, Chris?
Mm-hmm.
For me, I close everyone with a Minx. And, what I like about the Minx, that we've actually done a whole podcast on it, is that, it's all extravascular closure and, it's fairly simple to deploy. So I close everyone with the Minx.
Chris, you helped me out prepping for this podcast in a question that you had posted on SIR Connect about procedural meds, pre, post, and intraprocedural meds. So, I'd like to focus on that for a minute, but first I'd like to ask you guys, are either of you doing hypogastric nerve blocks?
Yeah, I am. And I am. And I'm a big fan of superior hypogastric nerve blocks. Yeah. And, why? Because the thing is, I stumbled upon this before. It's sort of, superior hypogastric nerve block at the SIR this year was much spoken about. And truthfully, I'd not heard from SIR before. We do a fair amount of interventional pain management, for spine and nerve blocks and celiac blocks and superior hypogastric nerve blocks. So I had a quite a few referrals for superior hypogastric nerve block for GYN pain. So, terminal cancer and stuff, where, I did this injection and then I did an alcohol ablation and it worked so well. So, got a couple of patients, and then I was doing a UFE one day and I was like, you know what, maybe it'll work for this. And then I looked up, there was some article back in 2004, was it, from Europe, which said it was safe. So I was like, oh, it's safe. So wonderful. So let me try it. And then it worked. And I don't know. I really haven't looked back, man. It is amazing. I know
Are you doing them using bony landmarks, or do you use your angiogram?
So at the end of the procedure, what I do is I pull back that catheter into the abdominal aorta and do like a roadmap, just with 5 cc of contrast, like just inject 5 cc, do a roadmap. So use that roadmap and then angle the II to make the 5 vertebrae like end on. And then, just go blind, man. Just don't look at what you're going. Just go blind and hit that bone. Yeah.
Chris, are you doing these?
I trained one of my attendings, Keith Horton, taught me how to do the superior hypogastric nerve blocks, but I don't. It sounds like Keith is probably getting his patients out same day. And if that were the case, I would definitely add that into my regimen. But I almost keep everyone overnight for pain control and antiemetics.
You do?
So, yeah, I do.
Oh, interesting. I found this trend a lot, which I'm actually surprised about. People keeping them overnight. I don't know. Back superior hypogastric nerve block helps a lot. Like it is amazing. I think everybody should start doing it. We're trying to get some prospective. We're trying to start to do a small clinical trial. Using the superior hypogastric nerve block, pending IRB approval. But I'm a strong believer of it. But even when several years ago, when we did not do the nerve block, my attending used to tell me, these patients have to go home. You keep them for 6 hours or whatever, but send them home. When they go home and they stay on their own bed, they sleep better and they're happier. I don't know how far it's true, but I don't know. I've seen a lot of people keeping their patients. So it's because of pain control, huh?
Yeah, that's why I keep them. I don't know if my patients are just wimps or maybe I'm just not tough enough on them to get them out of the door, but I think if I told them they had to leave the same day, they would just absolutely melt down.
Yeah. The thing is, the first few hours they get they are in discomfort and pain, so they get a little cranky.
Sure.
But if they know that they're going to go home the same day, I think you sort of put it in their mind and they have no option, then they go home.
Right.
I think so. I don't know. I don't know.
Yeah, I think it might also be like you said, like expectation management. Like if they know that they're going to go home, then
correct.
Get it.
Correct.
So here's how we're going to figure out if Chris is too tough on his patients. Why don't you tell us what you give medication-wise, pre-procedure, during the procedure, and after?
Chris, go.
Okay. So what do I give? I'm always like fine-tuning my regimen. And actually, Mary Constantino put a very nice post on the SIR forum. And and it was very detailed and very nice. And I thought I might just rip off hers. But so what I'm doing right now is pre-op, they just get Valium, and then intra-op Milversed, and then after I embolize one side, I will give them 30 milligrams Toradol IV, and then also after I embolize, I always go left side first. I do 5 cc's of intraarterial lidocaine. I think that helps.
Wow.
And then when I go ipsilateral side, after I embolize that side, I start their IV Tylenol and then also do the intraarterial lidocaine. So that's my intra-op stuff. And then afterwards, they go to recovery. We set up a dilaudid PCA pretty quickly. And then they're on some breakthrough pain meds, which I don't remember what I put them on. It's kind of part of my order set at this point. And then for antiemetics, I do Zofran. I do a scopolamine patch, which I think is kind of a helpful, savvy antiemetic trick. And I just put that on them regardless, like as soon as they're out of the procedure. And then they get a couple more doses of Toradol. I think I do 15 milligrams Q8 for a total of 3 doses, one of which they got intra-op, and then 2 throughout their hospital course.
I think during the procedure, as I almost follow the same thing you do. Some Versed fentanyl and Toradol on either side. I don't do the entire arterial lidocaine. Maybe I should start doing that. There's a good paper on it from Canada. Maybe that's a good option. Yeah, I like that. But after the procedure, no PCA pump, man. Not. Luckily, I have not required any PCA pump in the last one year. Not a single one.
Wow, that's phenomenal.
My patients have walked home between 90 minutes to 3 hours after the procedure. All of them.
Wow.
I may be lucky. Maybe with different patient population or what, but they have walked out. But they do have pain the next day, and so they're so happy after the procedure. They feel this is going to be the norm, but it is because of the block. So you have to educate them. Yeah, you have to because the block lasts for 8 to 12 hours. It doesn't last beyond that. So the next morning they're going to get up with pain. So I think I still do antibiotics. I do Cipro, Flagyl, ibuprofen 800 milligram TID, or naproxen 1000 milligram BID. One of them, either ibuprofen or naproxen. I think you need NSAIDs for these. You need, you cannot get away with opioids only. You need NSAIDs. This is an inflammatory reaction, so you have to get that. And then, Percocet and, if needed. And then antiemetic, of course. Antiemetic they don't really need unless they take Percocet and stuff. And stool softener. I think that's something that I've learned that, I used to miss out a few of them and used to say, oh, you know what, I'm constipated and I'm having pain. So stool softener is also important. Yeah, I think that's about it.
So Mary Constantino's list is in front of me. She said 30 minutes before the procedure, she gives OxyContin ER 10 milligrams PO, Reglan 10 milligrams PO. She does Emla cream on the wrist. During the procedure, she uses a nerve block. She's plenty of fentanyl and Versed. She uses 25 of Benadryl, 60 of Toradol, 4 of Zofran, which she starts to embolize. And then she also does intraarterial lidocaine. She said 5 cc's on each side. And then afterwards, she puts the patients on OxyContin ER 10 milligrams BID, Zofran 4 milligrams IV Q6 hours, Toradol 30 milligrams IV Q6 hours, and then plenty of oxycodone PRN. So we've got a lot of options. It's going to take some time for all of us to tweak and see what works best. Now, just to finish up with one last question, what's your follow-up of these patients like? Are you seeing them in clinic? What kind of imaging, if anything?
You can go ahead and start on this one, Keith.
Sure, thanks. I do try to see them in clinic. If they don't end up, we give them a call and see, oh, you're doing okay. We send them the score, of course. And, one thing that's important, and we don't follow much of it, is this UFSQL score. Have you guys heard of that?
I've heard of it, but I don't use it.
Yeah, it's pretty nice because many of these patients, it was I think Dr. Spies sort of wrote it up many years ago. I think it's important because a lot of patients start saying that, oh, I thought this would be better. I thought I would feel better, and you see the scores and you say, hey, these are the scores. See the difference. So, a lot of, because, this is not a surgical procedure, right? So they're just wondering, did this guy do something to me? Or, so I think those scores are important. And a lot of, as in prostates, we do the IPSS score. We have to go through the, an objective way of evaluation. So the scores, we may email the scores, they'll get back to us. Imaging wise, I don't know. I don't do anything at all unless there's a problem. 2 weeks ago, I had a patient who had mild low-grade fever on the 14th day after 2 weeks of antibiotics. And I was like, oh, you know what? This is a problem. So I got an MRI done. Of course, the fever went away and stuff. But unless there's a problem, no MRI. MRI is expensive. It adds to the cost for a lot of people. And again, we have to move away from being just images to clinicians now. It's time.
See, I always, my pre-op center gives all my patients a call a day after they go home. So it's like post-procedure day 2. And then I usually give my patients a call. Like I'll call and check in with them 2 or 4 weeks after the procedure. I'm moving more towards 4 weeks. It seems like if you call them at their second week, they just have a lot of things to talk about. And if you call them at 4 weeks, it seems like they are just getting over a hump. And so they'll tell you about how bad things were 2 weeks ago, but that 4 week mark seems to be like they're kind of getting over the hump of the recovery. And as far as a further follow-up, I always try and get my patients to come back in, but they oftentimes they just don't. or, they'll get in touch with me if they have a problem. But I'm always trying to get them in to come back and see me at clinic. And, I want to hear about how they're doing, and also, let them know that, the procedure went well, which I do actually when they're in the hospital also. But I try and get them in, and it's kind of a struggle, and I don't fight it too much. If I don't see them, then I just assume no news is good news. There are a handful of patients, though, that I do keep a closer eye on. It's if they have a pedunculated fibroid or, subserosal or submucosal, then the follow-up with them is a little bit tighter. And from imaging-wise, I don't order an MRI unless I'm anticipating a problem or a problem comes up. Mary Constantino, I heard her give a talk. She's come up a couple times now on this podcast, but I heard her give a talk at SIR, and she's really aggressive, I think, with treating, getting an MRI after and having potentially if she sees a problem, she believes in a clean endometrium. If she thinks that something's going to slough off, she'd rather have one of the OBGYNs go in and pluck it out early. I'm not that proactive, but it probably would be a pretty good idea.
I actually hit mute. So I think this really covers just about everything we needed to touch on. This is a procedure I think is sort of prototypical of our field and how it's transformed the face of modern medicine. We have a minimally invasive approach to a common condition with dramatically decreased morbidity and risk compared to surgical options. This really epitomizes the without a scalpel initiative. But as is typical of our field, there's plenty of variability in how we do the procedure and the techniques we use. And it's precisely this type of procedure where Backtable can be a vital resource. You can connect with your colleagues, learn what they're using and how they're using it, and find ways to do this procedure the best that we can. So for our listeners, download the app, use the website, and reach out to us on Twitter at @_Backtable. Let us know what you want to hear and what we can do better. Thanks, everyone, for joining us.